Yes. So I'm just thankful for giving the opportunity. So my 33-year-old male patient who came with sudden onset diminution of vision in the both eyes since 1 week. He had a high-grade fever and vomiting for 1 week, for which he was admitted in the government hospital. And he didn't have any history of diabetic or hypertension part of it. His right eye vision was 20 finger 1 meters in the same as in the left eye. Vision IOP was 24 and 22 in the right and left. In the anterior segment, when you see in the right eye, he had a pupillary membrane with AC cells 4 plus and the posterior synapse which was present, and there were some pigments on the lens was there, and RL cells also present in the right eye. Left eye has such there is no inflammatory markers are not there. And when you see the posterior segment, there are like mild vitreous haze was there. Along with that, optitis was looking okay. There was mild dilatation of the venules was seen. The few flame-shaped and intraretinal hemorrhages were also noted. Along with that, there was exudative retinal detachment on the posterior pole. And this is the same thing which can be seen in the left eye also. And in the periphery, in the both eyes, there was choroidal detachment. At around 270 degrees of choroidal detachment was noted in the both eyes. So when I went to the fluorescent angiography, there was some amount of inflammation and disc leakage which can be noted, and amount of hyperfluorescent areas also are noted, which indicates this is an inflammatory pathology which can be seen in the both eyes. So I went on with OCT. The OCT is like right eye. Actually, in the first visit, I didn't get so properly because a lot of exudative detachment was there. So in the left eye, it was much better. The right eye for OCTs of the next week presentation actually. So there was a neurosensory detachment and intraretinal fluid and RP undulations were all present in the both eyes. So when I did the B scan, there was a thickened retinochoroidal complex with a choroidal detachment of around 270 degrees on the both eyes which was there. So I thought this is a case of bilateral exudative RD with choroidal detachment. So now what can be the etiology having the both eyes having exudative retinal detachment with choroidal detachment? I went through that and I thought it can be an inflammatory VKH, Behçet's disease or mascarates or any other infective panuveitis. I went ahead with the further investigations. So blood investigation CBC showed neutrophilia, but the most important investigation which came positive is HIV ELISA, which came as positive, and the CD4 count he had was 53 millimeter, CD53 cells. Other MON2, VDRL, TPHA, everything was negative, and the urine culture showed me having the E. coli of more than 10⁵, which is significantly high. And the blood culture was negative because he was already started on intravenous antibiotics, broad spectrum, and it came negative. So based on this, when I went to certain literatures and all, then I came into the diagnosis of bilateral exudative RD with CD due to septicemia. Because there are certain cases which shows the septicemia, the increase in the E. coli will cause the inflammation and can lead to choroidal detachment and retinal detachment. Most of the time it should be endogenous end-off, what we see having a lot of vitritis and retinitis part of it. But it looks certain different. Only the positive treatment investigation report which I got was the urine culture and HIV positivity. So he was continued for intravenous ceftriaxone 1 gram 12th hourly, and I started on topical steroids and topical cyclophagics, and he was referred to AIT Center for the further management of the HIV. So on follow-up on these medications is systemic, he had a lot of fever and all which got recovered, and follow-up his visual acuity improved to 636 and right eye and 6/9 in the left eye. Fundus, there was exudative retinal detachment and choroidal detachment recovered, with hemorrhages are still recovering. The vessels and all which are dilated and also has been recovering part of it. Now he came, actually before I leave coming to the conference, he came for the follow-up, and he was 6/6 in the both eyes, and he was doing literally well. In the AIT center, they have started the medication for AIT, and CD4 count has also become better, now around 90 something. So this is the last follow-up which was shown, all the exudative detachment has recovered. So in this point, I thought it can be due to septicemia, and in my point of view, the reason for having the choroidal detachment with retinal detachment can be because of two things. One, can it be the infection per se, or second, it can be because the patient had severe fever and excessive vomiting. This excessive vomiting would have caused ciliary body shutdown and having a severe ocular hypotony, which had been lead to the choroidal detachment part of it. So this is one more case report. When I went through the case reports, I got only one case report where in this case they went ahead with a vitrectomy because intravenous antibiotics didn't work. So they went ahead with a vitrectomy, and then in the vitreous culture they saw they had a E. coli positivity. So in my case it recovered medically, so no need for any going to surgical part of it. So just my questions are, what can be the probable diagnosis, any other investigations, or how would you manage this case in a different way?
Yeah, thank you.
Yes, sir.
Was high.
High. 24
but
and 22.
You postulate that hypotony could be the cause of the choroidal detachments.
Yes, he had come maybe after the sudden vomiting and all, would have been caused a sudden hypotony. Afterwards, when there is a detachment occurred, by the time he reached to me, it was almost a 1 week post vomiting and all. It have been recovered. That's my hypothesis actually.
All the other features could be explained by the septicemia and the E. coli related events, but the choroidal detachment somehow yes. I am not able to figure out. Any
that's
thoughts
the
on?
Reason for me. That was my hypothesis why the choroidal detachment is.
Inflammatory choroiditis also is a possibility.
Yes.
Choroidal effusion.
Okay.
I think people have said that immune complexes get deposited. It's sort of local infarction. Transluminal pressure can build up, and that can cause transudation.
Transudation. Okay.
I just wanted to ask whether you did AC tap in your case, because the minute you had septicemia as your on the blood investigations, did you go and do an AC tap and see whether you're finding the same organism which is growing on the culture?
So actually I didn't do that because when the patient came, he came in a wheelchair. He was like very, lot of not feeling well very much. And first I thought, I didn't come into mind first, actually it is endogenous endophthalmitis or any septicemia part of it, because I had never seen having a bilateral choroidal detachment before. So what I thought, I'll send the initial investigations and let him come by 2 to 3 days, then I will plan for maybe vitreous biopsy only I would have planned for. By the time he came, he was becoming better. So I didn't go anything. Steroids I given only topical steroids. Oral steroids because he was retropositive, CD4 count 53. And is there any connection between retropositivity and this one? No idea.
No, those hemorrhages could have also been either endotoxin related because of the E. coli itself, or
Septicemia
even because of the microangiopathy which happens because of the HIV virus.
Yeah.
So those hemorrhages and the cotton wool spots.
Cotton wool spots were not there actually. Hemorrhages and vessel dilatation was there. Yes,
so those could be because of the microangiopathic process itself.
Yes.
But has leads to dilatation of the veins and hemorrhages also is very common.
Yeah, as Kumar sir was saying, I don't know why now when we checked it was 24 and 22 when he came for the first time, but still.
Very
intriguing case. Yeah, but nicely managed. But well managed.
Actually, nothing. Observation I did. That's the good thing.
The management worked.
Yes.
That is.
The only other point which probably, if you had a bilateral exudative RD with a choroidal detachment, initially itself doing an ICG also helps you to rule out the other inflammatory causes as well at the first instance. Just limiting yourself to a fluorescein doesn't...
I didn't have access to ICG.
Yeah, maybe, but doing an ICG also helps to rule out all your other choroidal causes.
So thank you, Sharath. Very intriguing case. So one heart thumping case and second intriguing case. So I would call my other